Plan leaders, October through December is the last quarter of the year. And you know what that means with gap closure, right? This is the window that makes or breaks your star performance and HEDIS results. And the truth is, you don't have the luxury of time. Every gap you close now does not only lock in performance for the year, but it will also set you up for the next year. So if you're watching this video, you already know Q4 is crunch time. But here's the good news. If you prioritize smartly, you can still move the needle in a meaningful way. But before we dive into strategies, I want to clarify something important. This video is different from my earlier Q4 strategy content on retro season readiness, where we focused on exclusions, data governance, preparing for successful chart chase season, chase list strategies. This is different from that. If you haven't seen that video yet, I recommend you check it out after this one, and I'm going to link it at the end. Let's dive in. And don't underestimate the value of your field staff and case managers in Q4. They are not just gap chasers. They are supplemental data sources. If trained correctly, the readings they collect can be NCQA accepted evidence. Combine that with targeted provider incentives, and you can turn your Q4 from a season of fatigue into a season of opportunities. It's about closing gaps, yes, but it's also about building trust, supporting members, and rewarding providers for the impact that they deliver. Now let's look at the medication adherence measures. Medication adherence measures are triple weighted in stars, which means they count 3 times as much as most other measures. For many plans, these 3 measures, adherence for oral diabetes medication, hypertension, and also cholesterol or your statins, are the deciding factor in whether they stay at 3.5 stars or move to 4 stars and above. Why does this matter in Q4? Medication adherence is calculated using the proportion of days covered, which is PDC methodology. This methodology, a member is compliant if they have their medications on hand for at least 80% of the days in the measurement year. So by Q4, the math is largely set, but members can still lose adherence status if they miss a refill. Conversely, near threshold members can be pulled back into compliance with 1 additional field. This means the October to December period is critical. Many members run out of medication during the holidays, or they skip a refill due to cost or travel, or they may switch pharmacies. Maybe they visited a relative in a different state or a city. If you don't catch these lapses now, the member drops out of the numerator. Here are some common pitfalls that plan faces with medication adherence measures. The last field drops. Members who were adherent through summer but don't pick up their final 30 or 90-day fill in December or in November or December. Number 2 is pharmacy fragmentation. These are members using multiple pharmacies where claims don't connect until after the year end. Number 3, common pitfall is benefit fatigue. Members on fixed income may skip December refill if the copay are due, or especially around the holidays. Number 4 is data lags, and by this time you see a gap in the claim system, but it may already be too late to salvage or even intervene. Here are practical Q4 strategies you can implement for medication adherence measures. Target last fill. Run pharmacy claims data weekly in Q4 and identify members who should have filled in their medication in the past 10 to 14 days but haven't. Outreach out to these members immediately. Utilize text, IVRs, pharmacy refills, or pharmacist calls, and prioritize members on 30-day fills. And you can do this by switching to a 90-day supply in October, which can lock compliance through year end. You can do this by working with PBMs and providers to override refill limits where clinically appropriate, and enroll members in auto refill and mail orders. Many PBMs allow mail orders, 90-day fills with auto ships. This will reduce drop-offs during the holidays when the member may forget or they traveled. A fourth strategy you can implement is asking retail pharmacy partners to run in-store point of sale adherence checks. An example, a member picking up insulin but not their ACE inhibitor medication. This triggers a pharmacist prompt to remind and dispense. A fifth strategy you can implement is offer gifts or OTC credits for members who picks up their last refills. Pair adherence outreach with holiday wellness messaging, and also medication synchronization. For polypharmacy patients, synchronize refill dates so they can pick up all their medication in one trip. This reduces the chance of partial adherence failures. The seventh strategy you can also implement is data reconciliation, and you can do this by working with your PBMs to reconcile claims versus fails. Sometimes a member picked up, a prescription that hasn't yet flowed into your system yet. So proactive reconciliation avoids unnecessary outreach. You don't need to wait until December. By then, it's too late for most PDC calculations. It's too late to salvage adherence. October and early November are your make or break window for medication adherence. If you don't take anything else from this video, remember this: medication adherence is the single most highest yield measure in Q4. It is 3-weighted. It's actionable and it's preventable. Plans that wanes in stars don't just push their members to start therapy. They make sure every last refill is picked up through December 31st. Missing one refill in Q4 can wipe out all the progress you made in the first 9 months of the year. Okay, let's look at COL, colorectal cancer screening. Still highly actionable in Q4 with the right approach. Here are some tactics. Distribute your fit kits in October, November with rapid follow-ups to ensure return before December 31st. Also follow up on members who you have previously sent your fit test and have not returned it yet. You can send text messages, reminder calls, emails, or even work with your case managers or providers to remind these members to complete their screenings and return the completed screening to the lab. Colonoscopies already completed within the 10 years, confirmed documentation is captured. Many gaps are false negatives due to missing supplemental data. So assign staff to chase down colonoscopy reports already on your file with provider EMRs. Now let's talk about SPC, which is your statin medications. They are unaddressed or under-addressed, but a very straightforward win. Pull a list of medications with ASC VDs who aren't on statins. Push provider alerts and pharmacy interventions to initiate a therapy, and also focus on members most likely to respond. These are members who are already on multiple medication but are missing a statin medication. Let's talk about cervical cancer screening measure. Harder to close late in the year, but worth targeting. Partner with OBGYNs and your FQHCs to schedule screenings. Confirm HPVs plus the PAPCO test results for women 30 to 64 years of age. One compliant test can lock coverage for 5 years. So scrub supplemental feeds. Many completed screenings sit in EMRs, but not in your HEDIS data. So scrub your supplemental feeds. Let's move on to the well child visit, which is WCV and W30. Pediatric measures are notoriously challenging in Q4. Some tactics here you can use: leverage flu shot campaigns and holiday clinics as opportunities to add awareness exams, and train providers to convert an acute visit into a well child visit by adding anticipatory guidance and proper coding. The impact here is even the modest improvements can improve CAHPS' perception of child's care experience. Let's talk about immunizations. This is your IMAE CHLs, HPVs, and flus. Vaccinations are still year-end opportunities. Here are some tactics you can implement. Partner with pharmacies, schools, and retail clinics, and document all vaccinations administered outside traditional health systems, because many remain uncaptured. The impact here is these measures also influence member experience. Families who see proactive outreach around immunization often rate access and plan support higher. CAHPS stands for Consumer Assessment of Health Care Providers and Systems. It's not just another survey. It accounts for over half of the star ratings weight when combined with member experience and access measures. So unlike clinical measures that close with a test or a refill, CAHPS is about member perception, which is shaped all year long. Importantly, CAHPS surveys questions in the spring ask members about their care experience in the past 6 months. Follow me for more insight, practical strategies, and thought leadership in healthcare quality.